everyone. Welcome and happy Valentine's Day. I see folks are popping in here. Looks like we've got a nice group already. Thank you all for joining today. Before we get started with our didactic, we are going to start as we always do, just having us all kind of check the pulse with how we're feeling, and then doing a brief mindfulness or grounding activity to sort of address any feelings of burnout we might be having and bring us into the room. So let's launch our poll. If you all wouldn't mind just answering that quick question, kind of checking the pulse, how you're feeling lately. And as those are trickling in, I'm going to turn it over to our hub member, Evan, to lead us in a brief mindfulness.
Thanks, Lauren. Howdy, everybody. Nice to see you on this Wednesday. So I am going to lead you through a brief mindfulness activity, and I like to think about activities that can be done kind of throughout the day. So this kind of fits there as well. Feel free to keep your camera on, turn your camera off during this. If you have a pen or a pencil, some sort of drawing device, you can use that. If not, you can use your finger. And so I'm going to go ahead and get started. So what I'll ask you to do is first pay attention to your breath. Take a deep breath in, deep breath out, and keep breathing in and out, trying to breathe out just a little longer than you're breathing in. As you do that, I have my pen. I'd like you to put the pen to paper or your finger to the table, and we're going to draw a swirl in a circle going outwards. There's no specific number of swirls you need to do or speed, but I'd like it to help you bring your attention to what the pen feels like in your fingers and what your swirl looks like on the paper. Paying attention to any urges to move faster, slower, and any judgments that you might have about your swirl. Keep breathing. Do this for another about 20 seconds. It doesn't have to be perfect. And when you're ready, you find a natural place to stop and put the pen down, kind of wiggle your fingers, maybe give a little fist, get those wiggles out and bring your attention back. And I realized as I was doing that, I had my own judgments coming out of my mouth about this doesn't need to be perfect. So I hope that you all were able to kind of reflect on any judgments, thoughts, or feelings that you had as you were going through that activity. Thanks, everybody.
Awesome. Thanks, Evan. So before I introduce our hub member who was our speaker today, I would just invite everyone who's able to turn your cameras on so that we can keep developing our learning collaborative together. We'll start with the didactic, and then about halfway in the hour, we'll move to our case-based learning. So today, to start, we have Dr. Lindsey Bruett, who is a psychologist and associate clinical professor of psychiatry and behavioral sciences here at UCSF. She provides clinical care and supervision in eating disorders, anxiety, depression, trauma, OCD, suicide and self-harm, gender diversity, and behavioral parent training. She leads the eating disorders program at the Zuckerberg San Francisco General Hospital and is the adolescent mental health training lead at the hospital and an associate program director for the UCSF Child and Adolescent Psychiatry Fellowship Program. Without further ado, take it away, Lindsey.
Thanks so much, Lauren and Evan. Nice to see everybody today, and really nice to start to be seeing some familiar faces and recognizing folks. Alrighty, see if my slides will cooperate here. Okay, so a little bit of information about our funding sources. We don't have other financial disclosures today. So we're going to be talking about eating disorders, particularly in school settings. And I really spent some time thinking about our audience in this group, which is a lovely, varied group of folks who have kind of different roles in school settings. And so, of course, as you know, some of you provide direct care to students and young people. Some of you are involved in school settings in other capacities. And so really tried to think broadly about what sorts of things do we all want to keep in mind, kind of regardless of our role with young people in schools. Some of the areas that I refer to in terms of screening or making referrals may not be consistent with your role. And so I invite you to sort of take in the information that we've provided and think about how it can apply to your particular role in your school setting. So eating disorders are serious. They are the second most deadly of the psychiatric disorders. They were recently sort of overtaken by opioid use disorder. Unfortunately, they have high rates of death and other medical issues that are caused by eating disorders. So really glad you're all here today to learn more about them. There's some unfortunate myths that have persisted in the world of eating disorders that unfortunately have gotten in the way for many individuals impacted by eating disorders in terms of their ability to access and be provided with appropriate care. So one is, and this is one of the most important, is that eating disorders can present at any weight across the spectrum. You cannot tell if somebody has an eating disorder by looking at them. Eating disorders are not choices. People don't choose to engage in these behaviors. They're biologically influenced illnesses. We're learning more and more about the relative genetic contributions to eating disorders, and it is quite strong. Treatment doesn't rely on a patient's desire or willingness to recover. We'll talk more about the fact that for many eating disorders, the illness itself can actually make it difficult for folks to kind of see the full scope of the problem or sort of consistently feel that there's a problem with their health. And so they really, we as providers and as loved ones of folks with eating disorders may need to assist folks in getting the care that they need. Finally, in many areas of mental health, this won't be a surprise to folks here, but in many areas of mental health, we have this unfortunate history with blaming families for mental health conditions, particularly mothers. This has happened in eating disorders, and unfortunately, that belief still persists. And we know that that's not true. Families don't cause eating disorders, parents don't cause eating disorders, and in fact, we need them to be critical allies in the treatment of their young ones. And finally, that full recovery is absolutely possible. And the best predictor of full recovery is early intervention and folks getting evidence-based care as quickly as possible. When we're talking about eating disorders, what are we talking about? So in school settings, generally speaking, we're not asking folks to be diagnosticians and sort of figure out what type of eating disorders somebody is experiencing, but I do want folks to know kind of what we're talking about here. So these are the disorders that we typically see in our eating disorder clinical setting. There are other eating disorders in the diagnostic and statistical manual, but these are the ones that we see the most. The ones that I want to call out are atypical anorexia nervosa. So this is when somebody experiences all the signs and symptoms of anorexia nervosa, but their body weight falls within the normal overweight or obese range according to the CDC. So, and then finally, ARFID, avoid and restrictive food intake disorder, is kind of the new kid on the block in the eating disorders realm. And that refers to folks who have either very low appetite that's not tied explicitly to body image and or very severe restrictive eating and or a fear of aversive consequences of eating. So that operates a little bit differently than our other eating disorders, but some of the treatment targets are the same. Eating disorders impact everybody. They don't discriminate. And just like the other myths that we were talking about with eating disorders, there's been kind of an unfortunate belief that eating disorders only or sort of typically impact folks who have certain identities, namely being white, cisgender, females who might be middle to upper middle class. And we know that that's a myth. Everybody is impacted by eating disorders, and in fact, certain minoritized groups are impacted at higher rates than others, and we'll talk about that. So if you take nothing else from this slide, I hope that what you take away is that when we look at epidemiological data on who is impacted by eating disorders based on race and ethnicity, we just don't see that many group differences. There's some kind of trend level differences that can be detected. When we look at bulimia nervosa, for example, we in some studies see Latinx and Black young people with highest prevalence rates compared to white and Asian individuals. But in general, there just really aren't that many group differences amongst various racial and ethnic groups. And this is surprising to many folks. However, we know that folks who are in racial and ethnic groups that have been minoritized are much less likely to be screened for eating disorders, to be asked about eating disorders at medical visits, and to be referred for appropriate care. So really good, myself included, to kind of check our biases and remember to be kind of expansive in who we're thinking about could be potentially impacted by the problems that we're focused on today. Socioeconomic status is not associated with eating disorders. So folks of any socioeconomic status experience eating disorders at similar rates. However, food insecurity, so the presence of food insecurity is associated with an increased likelihood of somebody developing an eating disorder. And that kind of makes sense when you think about it. We know that any kind of disruptions in nutrition can put somebody at risk for eating disorder, whether that's purposeful or not. And so when folks have experienced food insecurity, that can impact their symptoms or later development of symptoms. Many boys and men develop eating disorders. When we look at the kind of whole population of folks with eating disorders, approximately a third of those folks are boys and men. And then finally, when we look at minoritized sexual and gender groups, we see higher rates of eating disorders among folks in those minoritized groups. And that's probably for two reasons. One is kind of following the minority stress framework, that when folks are in minoritized groups, they unfortunately tend to experience more stress and stigma, which can increase mental health concerns in general, including with eating disorders. And then also that sometimes the eating disorder may serve a function to influence weight or shape in order to affirm somebody's gender or sexual identity. Most eating disorders occur in individuals with body weights in the average or higher categories. So we talked about how we can't tell by looking at somebody who has an eating disorder. And I think we as a society tend to, maybe not folks in this room, but many folks kind of tend to think that, okay, but like most people with eating disorders live in bodies that appear thin. And that's actually not true. Most folks with eating disorders live in bodies that appear in the average or higher range. We also know that for folks with anorexia nervosa type presentations who are in average size or larger bodies, that the medical complications of weight loss that they experience are just as severe as the complications experienced by folks in bodies that fall into the underweight category as defined by the CDC. So, and additionally, their psychological symptoms can actually be more severe. So we really do need to pay attention to folks in all body sizes when we're thinking about eating disorders. Okay, so screening. So you all probably are busy. We can see that from the burnout poll at the beginning that you all have a lot going on. You probably are attending to, taking care of, working with multiple students throughout your day. These are 4 questions that have been published and shown to have reasonable kind of specificity for screening for eating disorders. So again, not everybody in this room is sort of in a position where it makes sense to be screening for eating disorders, but if you are, these would be 4 questions that you could consider adding to your interviews with students, or if you're concerned, you could consider asking these questions. Okay, so what are some warning signs of eating disorder? not limited to these, but these are kind of the big ones that we often come across. So any kind of changes to diet, skipping meals, cutting back on food intake, this can often be, eating disorders can sometimes operate in a way of being kind of secretive or trying to sort of hide their presence from loved ones, whether that's family or friends, teachers, things like that. And so sometimes young people who are in school may sort of eat normally at dinner time at home if they're with their family, but might be skipping breakfast and lunch at school and kind of trying to go under the radar in that way, or the eating disorder trying to go under the radar. Major changes in exercise, so really exercising a lot or in kind of a driven or maybe having a compulsive quality to it. Avoiding eating with other people, lots of body comments, or families will sometimes describe noticing their young person looking more often at reflective surfaces or seeming to like touch or measure certain parts of their body, or the opposite, starting to wear baggy clothing, which we can see as sort of like an avoidance strategy for folks to avoid looking at their body. Certainly any sort of the signs of vomiting, we would want to pay close attention to. Oftentimes at the onset of an eating disorder, folks will become vegetarian or vegan. And sometimes this is sort of an effort to have like a culturally sanctioned way to engage in restrictive eating. Sometimes we see folks deciding to become vegetarian or vegan for other reasons. And then that sometimes can present a situation where the individual isn't getting enough nutrition, and that can sometimes be a precipitating factor for an eating disorder. So this is absolutely not to say that everybody who becomes vegetarian or vegan has an eating disorder or will develop one, but we sometimes see those two things being tied together. And then just kind of general interest, like increasing interest in food, but not in actually eating what they're cooking or checking out on the internet. If you're noticing things and you're in a position where it's part of your role to be assessing or taking care of kids with medical concerns or mental health concerns, these would be the other areas that I would recommend assessing. So assessing thoughts and behaviors associated with nutrition, exercise, and body, and relatedly any compensatory behaviors. Compensatory behaviors can also include fasting, so going for long periods of time without eating. I want to note this point in the bottom right corner here. So for many folks with eating disorders, I would say particularly for young people, they may not ever express an explicit desire to have their body look a certain way or to lose weight or to become more muscular. And that can be, we think, for two reasons. One is they may really not experience that. That may not be what their eating disorder is about. And the other might be that they might be kind of protective of their symptoms and sort of not comfortable disclosing their symptoms because they might worry that folks will intervene. And so we want to make sure we're not kind of waiting for somebody to tell us that they have body image concerns before we raise our concern flag about potential eating disorder. Okay, so I know that not everybody in this room probably spends a lot of time working with patients and caregivers together. You may or may not have much contact with caregivers, given that most of you or all of you work in a school setting. But there are typically differences in how patients and caregivers may report eating disorder symptoms because of that idea that sometimes people who are experiencing eating disorders because of the impact of malnutrition on the brain may not have a clear sense of sort of may not see things in the same way as the other people around them. So they may not kind of experience their eating disorder as something that's a problem or something that they want to change, whereas often loved ones or caretakers or medical providers are quite concerned. And so we'll see these differences in sort of how people will report their symptoms. And this is not patients trying to be, or students trying to be difficult or trying to be secretive. It's the way in which eating disorders operate and part of what makes them somewhat challenging to support and work with, but worthwhile. Okay, so what do you do if you're concerned? These are some tips that I put together. So one would be talking with the student and or the family, depending on what's appropriate given your relationship, and really coming from a place of using those I statements. So I've noticed, you know, Susanna, that you've been skipping lunch the last few weeks and I'm concerned about that. You're not in trouble. Can I ask you a little bit more about that? You might consider providing resources. We know there's tons of information out there on the internet on eating disorders, and a lot of it is not evidence-based. So we've put together a packet of evidence-based materials that you can give directly to families if you would like to. And we have a QR code for that at the end of the talk. That's on our CAP website. Ideally, if you're in a position to, you would support in some way facilitating the student to get in to have a checkup with their PCP or pediatrician. I know some of you work in school-based health centers, so that might actually be your role, or some of you might be maybe talking with the family or even the student themselves to try to help them get an appointment for that. We do have other trainings through CAP that provide more clinical tips. So if you are a provider, either mental health or medical provider, you might want to check out our webinar series where we have a deeper dive on clinical tips for eating disorders. Some schools, so I run the eating disorders program at San Francisco General Hospital, and I have certainly had school staff, particularly mental health providers, refer kids directly to me to our clinic for eating disorder treatment. We do need parent permission for that. And then I would recommend following up. So we know that sometimes it can be difficult for families or students to follow through with our recommendations for a variety of reasons, especially those who may have more kind of psychosocial stressors that might get in the way. So I'd recommend following up, and if it's appropriate, to offer to help them with that process. Okay. So one of the tricky things about eating disorders is often there's malnutrition involved, whether that's restrictive eating that's causing weight loss, or kind of disrupted eating patterns that may not result in weight loss, but still are kind of impacting the folks getting consistent nutrition throughout the day, throughout the week. And we know that malnutrition causes brain changes. They're reversible for the most part, but that it causes people to have difficulty kind of having an accurate appraisal of their own health, of their body image, things like that. And that when nutrition is restored, that cognitive functioning really gets much better. People are able to think more clearly about food, exercise, their body when they're better nourished. And so you'll see why this is important kind of in our treatment approaches. So the nice thing about all evidence-based approaches for eating disorders is that they carry some kind of common core areas of focus, even though there's several evidence-based treatments out there. So one is that the initial treatment targets are behavioral in nature. So if somebody needs to gain weight, we're really focused on that in the early stages of treatment. We're supporting them to normalize eating patterns, reduce compensatory behaviors and binge eating. And once we do those things, the psychological components of eating disorder, so worry about weight and shape, body image concerns, those things tend to get a lot better on their own. And then sometimes we do some psychological intervention with those things as well. I wish that I had a magic wand that would help to reduce body image concerns without starting with the weight and nutrition piece, because it would make my job so much easier and the lives of the families I work with so much easier. But unfortunately, that's not the way it works, or at least not the way it works with the current treatment tools that we have. Okay. All right. So thinking about the fact that, a reality is that evidence-based treatment is limited, and it can be hard to support families to connect to that care. It may not be available in the community that you're in. So these are some tools that you can use to support young people experiencing eating disorders while they're awaiting care, or if care unfortunately never becomes available. So one is motivational interviewing, about sort of leading the person toward a recovery mindset. So pointing out ways where the eating disorder might be getting in the way. Often there's some ambivalence. There might be part of the young person that wants to change these behaviors and recognizes they're unhealthy, and there might be part of them that feels stuck in the eating disorder. And so we want to help lead them toward that recovery mindset, and motivational interviewing is a great strategy for that. Another is active coping. So things like distraction, other kind of active skills, deep breathing, things like that, to help reduce the stress that can be associated with eating, whether it's before, during, or after meals, or kind of other times when they're having body image concerns, things like that. We want to stay away from more passive techniques like mindfulness or tuning into body sensations, because that the eating disorder will be too active during those times. And then really reinforcing any small changes that are oriented toward recovery. Okay, so some tips when you are coming into contact with students who are maybe experiencing eating disorder. One is to avoid commenting on appearance. You can see on the right-hand side of the screen here that we may be trying to give somebody a compliment or encourage, but the eating disorder may hear it in a different way. And I would say in general, I just try in my practice to avoid commenting on folks' appearance. It just it's not usually that helpful and can be kind of risky depending on what the person is experiencing. So I try to just find other things to talk with folks about. Another is to not collude with the eating disorder. So if somebody says, I feel fearful of eating cookies, we don't want to say like, oh, that makes sense that you feel fearful. We might validate in another way, like saying, oh, it sounds like that's really hard for you. But we want to be careful to not kind of reinforce eating disorder related concerns. Another is to avoid shame when folks are disclosing things like binge eating or even restrictive eating, things like that. They may experience a lot of shame about their symptoms. I think this can be particularly true really for all individuals, but particularly for families who may have increased stigma around mental health concerns. And so we really want to, of course, treat those disclosures with sensitivity. And finally, if you are working with a student who is in treatment for eating disorder, because it's the role of the eating disorder therapist to push back against the eating disorder and uphold the healthy side of the young person, especially in the early stages of treatment, my patients are not always like thrilled about working with me. And so we want to think about that when we're kind of talking about with students about their experiences in therapy, that, of course, if you hear something that concerns you, you want to intervene just as you always would. But if the young person is experiencing ambivalence about treatment, that is not abnormal in these types of treatment frameworks. Okay, so finally, just thinking broadly about protecting students from diet culture. We know, unfortunately, we live in a society where there's, billions and billions of dollars spent on promoting diets, on promoting weight loss drugs. Like these things are all around us. And so I wanted to offer some things that you can do if you would like to work on protecting students. We know that you are role models in your school, that you have students who look up to you. And so it does matter what we say and what we do. So one is that when we look at predictors of eating disorders, dieting is one of the most powerful predictors of folks developing eating disorders. And so if you're hearing about students engaging in dieting behaviors, if you're in a position to do so, I would recommend certainly not encouraging dieting behaviors and even talking to students about the dangers of dieting and the fact that, again, that the diet industry is a multi-billion-dollar industry, and if diets worked in the long term to promote weight loss, then it wouldn't be the industry could end, right? We know that dieting actually predicts weight gain in the long term and predicts weight cycling, which is a poor predictor of other health concerns. Considering your language and behavior around food and body, I still remember being in 9th grade and my Spanish teacher, who I love dearly, she's a phenomenal person, but I remember her saying, like, I just learned that if you eat an apple and a glass of water, that it makes you feel full as if you ate lunch. And like, I still remember that. And so just thinking about, everybody struggles in their own way. And so if you're engaging in dieting or if you have body image concerns, like that's very understandable, and to just watch what you're saying out loud or doing in front of students, because they might remember those things. Promoting physical activity is something that's good for general well-being and or enjoyment, but not aimed at influencing weight or shape. Family meals are one of the kind of prevention strategies for eating disorders that seems to work. And the family meals are also predictive of other really good well-being outcomes for young people, as you may be aware. And so to the degree that you have contact with families, and this is something that you can encourage, I know it can be tricky for busy families, that can be a really helpful thing. And it doesn't need to be homemade food. It doesn't need to be every single day. Kind of any time the family is able to sit down and share a meal together, that seems to be quite helpful. And then finally, we know that kids are savvy, and they sort of like to be able to understand what society is trying to sell them. And so thinking about media literacy, if the opportunity presents itself, you might talk with students around, like, what are advertisements trying to sell us? How do they do that? How does kind of like body ideal persist in our media, and how is that dangerous for us, and how can we kind of protect ourselves against that? Okay, so some takeaways here. Thank you all for your time and attention. I really appreciate it. And finally, these slides will be shared, but we have a QR code which should lead to our resource guides on our CAP website. You can also just Google UCSF CAP eating disorders and our resource guide should show up. So thank you all so much. I appreciate it.